Good day, everyone. We welcome you to the second installment of a two-part pharmacy town hall series brought to you by HIMSS and NCPDP, the importance for the healthcare industry to establish universal patient identifier. HIMSS is a collaborator for the Pharmacy Town Hall series. HIMSS is a global advisor and thought leader supporting the transformation of the health ecosystem through information and technology. As a mission-driven nonprofit, HIMSS offers a unique depth and breadth of expertise in health innovation, public policy, workforce development, research and analytics to advise global leaders, stakeholders, and influencers on best practices in health information and technology. HIMSS' vision to realize the full health potential of every human everywhere. For more information, please visit www.himss.org. NCP also serves as a collaborator and sponsor for this series. Founded in 1977, NCPDP is a not-for-profit ANSI-accredited standards development organization with over 1,500 members representing virtually every sector of the pharmacy industry. NCPDP members have created standards such as the telecommunication standard and batch standard, the script standard for e-prescribing, the manufacturer's rebate standard, and more to improve communication within the pharmacy industry. You can learn more about NCPDP by visiting www.ncpdp.org. To introduce our speakers today, John Hill is Executive Vice President and General Manager with the National Council for Prescription Drug Programs. Under the direction of the President and CEO, Hill oversees and is responsible for all day-to-day business of the organization and leads the executive management team in achieving financial goals, operational performance, and provides strategic support to NCPDP's President and CEO. John has a BA in Communication Studies from University of Missouri and an MBA in Healthcare Management from University of Phoenix. In 2019, Hill received his certification as a Nonprofit Executive Director from Nonprofit Web Advisor. Our next speaker is Victoria Dames, Senior Director, Product Management for Experience Health. For almost 20 years, Victoria has focused on building technical solutions across credit, marketing, and healthcare. As a Senior Director of Product Management, Victoria is responsible for evolving products within healthcare around fraud and identity management. Victoria grew up in Chicago, Illinois, and holds a Master of Science in Business Information Technology from DePaul University and a Bachelor's in Computer Science from Loyola University, Chicago. Participants of this session who complete the evaluation form and provide accurate CPE Monitor e-profile information will have their credit for 1 hour of continuing pharmacy education submitted to CPE Monitor within 60 days of this event. Next slide. Next slide, Tammy, with you the presenters. Next slide. And so now I'd like to pass the presentation over to John Hill, who will walk us through the learning objectives. Thank you, John.
Thank you, Yvonne. Good morning, everyone. Today, under our presentation, we will review the role of HITECH Act of 2009 to digitize health data. We will also define the term Universal Patient Identifier, UPI, and its role with digitized records, outline how UPI will effectively and accurately link health data to support patient safety, and finally, we'll report the legislative process to pharmacy industry and progress to transmit UPI through NCPDP standards. Next slide, please. And part of the pre-test questions as you're reviewing this presentation today, why are we just now creating a universal patient identifier? Why is the universal patient identifier important? And finally, what are some causes of duplicate patient records? Next slide, please. For over 40 years, NCPDP has led a transformation in the pharmacy service sector by creating and promoting standards for electronic healthcare transactions. Our collaborative consensus-building process has produced operational efficiencies that save $30 billion annually in healthcare costs while increasing the safety and quality of patient care. NCPDP and the pharmacy industry have developed solutions to problems that continue to challenge the rest of healthcare. NCPDP standards are named in federal legislation, including HIPAA, MMA, high-tech, and meaningful use. We advise regulatory agencies and actively participate in the rulemaking process. We also educate legislators about NCPDP's problem-solving form and consensus-based solutions and serve as a resource to policymakers. These include real-time claims adjudication, eligibility and benefit verification, real-time ordering by the physician, and sharing the medication history. The lessons we have learned can be valuable to other healthcare sectors. Next slide, please. The work of the organization is accomplished through its members who bring a high-level expertise and diverse perspective to our forum. NCPDP currently has 3 membership segments, including producer-provider, vendor general interest, and payer processor. We currently have over 1,700 volunteer members that support developing and improving our standards. Next slide, please. When NCPDP started tackling the issue to improve patient safety through improved patient matching to support preventable medical errors as the number 3 killer in the U.S., our board of trustees was adamant that we aligned with a technical partner that shared our vision and purpose in leading the industry in healthcare standards and solutions for the common good. To this end, we partnered with Experian Health as they were the right technology partner for NCPDP in moving this critical issue forward. Next slide. We believe there is a convergence gaining momentum through technology and standards that significantly improves patient matching through UPI powered by Experian Health, UIM, and NCPDP standards. We have made a joint no-charge offer to the industry to use Experian Health's technology and the Experian consumer database to identify record matches and duplicates, and then assign a unique UPI to each unique patient in the file. And the process piece of moving the unique patient identifier along with the patient information through NCPDP standards adds an extra layer of protection. It establishes the foundation for exchanging patient information across the healthcare ecosystem to reduce medical and medication errors, improve care coordination, population health management, and also improve prescription drug monitoring programs. And it also addresses the business need, reducing the human and financial resources needed to reconcile duplicate records and billing and claim errors. Next slide, please. The right process is through standards. We have solid proof that standards make healthcare safer and more efficient. Standards are seamless, behind the scenes, making it possible for a prescription to be transmitted electronically from a doctor's office to the pharmacy. Our standards set the framework for an interoperable healthcare ecosystem. I am happy to report earlier this year, industry approved the use of the NCPDP Universal Patient Identifier, which we call the UPI, to be used behind the scenes, transmitting the patient identifier along with patient data through our standards. And today, Experian Health has enumerated 100% of the U.S. population, so that the unique identifier exists for an estimated 328 million Americans and is growing every day. At this time, I'd like to transition the presentation over to Victoria, which will provide a deeper dive around the issues surrounding high tech and our approach and methodology.
Thanks, John. And thank you all for joining. I know that this is a holiday week and we're getting into the holiday season, so appreciate everyone making the time today. I'm coming off of an illness here. If I may go on mute to cough, just a warning, so don't worry, you're not losing audio in case that does happen. So John covered an overarching problem and solution that we have today in the market, and I'm going to kind of walk us through the history here of how we got here, why it's important, what it is, and a few different other factors that are important to understand as we cover pretty much a 10-year journey here. So we're going to start with the HITECH Act of 2009, and if you all take a brief minute and think about where were you 10 years ago, and I know for some of us that might constitute a pretty big chuckle. For others, you have to scratch your head and think where you were. But 2009, Obama was first sworn into office. It seems like a lifetime ago. The iPhone had been out for about 2 years. And that's kind of a critical piece as well as we talk about both legislation and technology. So what is the HITECH Act and kind of how did it come to be? So we have HIPAA in place, and we have had HIPAA in place for some time. And what the HITECH Act really does here is it gives the muscle to HIPAA. And what it did promote here was all of those paper trails that we see, and I'm sure many of us can recall going to a doctor, dentist, any medical office and seeing the wall, the famous wall of files, all just with your healthcare information sitting there available for anybody to walk up, take, look at, check. You might have one, you might have two, you might have 3 records there. You just don't know. Something can get misplaced. Another record gets created. There was a really strong push to take that and actually digitize it, and that's what we're here to cover, is how are we, how did that HITECH Act really digitize, the health data, and then what have we built off that? So there's a lot of different layers and things that are going to come together for us today, but the HITECH Act started that. It forced the hand for the healthcare industry to ensure that things became digitized, electronic, and we can start those fundamentals around interoperability and moving information as well as securing it. So there's a lot of benefits to this, and that was really the start of it. So I know I can recall, 10 years ago, I was not looking, into a patient portal, for instance, to make an appointment or even view my records. So we have definitely come a long way here to get us where we are today. And as a patient, as a consumer, throughout that ecosystem, the benefits that we get from that. So next slide, please. So the HITECH Act was February 17th, 2009, and that goal was to promote the adoption of electronic health records. So there was $19 billion to be used to increase this. So there was incentives provided to folks on moving and utilizing that data, both by physicians and hospitals. And as you can understand, those organizations are tough on funds. It's tough to make choices where to invest, and this really promoted that push. So hospital organizations, other industries, labs, pharma, et cetera, there's always a budget every year, and you're trying to make the best decisions that are also going to increase your patient experience, but also your efficiencies and your operabilities. This HITECH Act really kind of gave a very good nudge and push, as well as gave a little bit of forgiveness to folks and incentivized them to use it. Also tightened up around the HIPAA language. So we have seen now there is no shortage of stories around potential breaches or notifications. It tightened up that language around notifications to the consumers and disclosing information on if perhaps any of that data does get mishandled. That's leaps and bounds for healthcare. Otherwise, you would not know. There was no way even to track, trace, and gain that insights. If you think about other industries, again, 2009 to 2019, in your financial world, the minute your credit card is run. You will know, if you have an Apple Watch perhaps or any other notification, you'll get an alert, an email, you can get a phone call. And so this kind of helps bring healthcare moving it much more forward into the 21st century here. And they also instituted after 2015 tougher penalties. So while we did incentivize originally to get things going, there are tougher penalties that did come into play. So we want you to adhere, but then we're going to slap your hand make sure that you stick to this. So it's very important, and they struck a balance on making sure that we get folks engaged, get organizations electronically getting records there. This sets the foundation for interoperability between a lot of different organizations and healthcare journeys. So again, I mentioned patient portals, pharmacy apps. You get your, love the convenience of getting a text when my prescription's ready. I could refill from there. It really makes life easy, and I feel that personally, the iPhone really has changed the way we live in a lot of ways in terms of convenience and interoperability, and it should only naturally extend into these other areas as well and really push the technology aspects to kind of catch up. Next slide. So how is the adoption actually, how has it been going? How was it? What were we really looking at? This graphic here just shows, from 2004 to 2017, kind of that rate of adoption. HITECH Act was right there in 2009, saw that increase. 2011 to 2015, you saw a much stronger shift. And, today we're seeing most everybody is up already on an EHR. So that's important. Why is that important? Because that is one of the places where that UPI can be assigned so that we're tracking, a full view of that patient, whether it is in an EHR system, whether it's in a pharmacy, et cetera. Next slide. So that was a little bit around EHR systems and, typically providers assigning that, et cetera, but let's shift a little bit into the electronic prescribing timeline. This is obviously not extensive of everything. I've specifically pulled out a couple key milestones for this presentation that I think are really important to hit on and call out for everybody. Excuse me. So in 1997, NCPDP started this journey, and they released the first script standard. So that was obviously well in advance of the HITECH Act coming out, but also in advance of meaningful use, which we'll see later on here on the third ring here. In 2007, e-prescribing was legal in all 50 states. So that is just before, and again, I think iPhone came out 2007, HITECH Act comes into play in 2009. So all of this is kind of moving all together at once and forming. 2010, we had meaningful use, stage 1 and 2, and the NCPD script standard was also named in there. At that point in time, there's a metric of 326 million electronic scripts. I think it's interesting as we kind of jump forward, that adoption rate increases dramatically, and I think that obviously that journey and that trajectory is in line with other parts of this industry as well. So if you jump ahead even a year or two, those electronic prescription rates doubled to 788. And it really shows that we're shifting to leverage that technology, obviously for the good of the patient. 2013, we went ahead and created, the NCPDP created a standardized workflow and format for electronic prior authorizations. And then 2014, we're already jumping to 1.2 billion prescriptions moving through. So, the focus and what I really want everyone to take out of here is that this trajectory and the sophistication curve of how we're enabling technology, pulling that into healthcare, kind of the guardrails and standards that are being put into place, how this is all coming together across the board. And then obviously in 2018, a huge milestone here is that the NCPDP had 3 DERPs approved to add that UPI into the standards. And that's a very big, huge accomplishment for us because we want to be able to ensure both of our organizations that we're ensuring patient safety and that we're starting to lay this foundation to keep continuing to build off of it. Next slide, please. So we understand the HITECH Act. In an overview, the importance, how we're digitizing this, and the advancement, obviously, of technology at play in healthcare, which is great. However, the greatest gap that I think we still have is in the industry interoperability. So what does that mean? It's our main focus really here still is our patients. Doesn't matter what part of the organization within, it's our patient. And we continue to see these headlines that come up around misidentifications. So there's no shortage of them. You can Google it yourself, listed a few up here, but 14 instances of the right procedure, wrong patient. Most recently, we were just talking with the NCPDP about this. You know, in New Jersey, there was a very story that made the headlines around a kidney transplant between two patients, and very similar names, and the priority was different. And so there is no shortage of these events happening, and it's important to understand why they're happening, how do we mitigate them, what the cost is to the industry, to the patients, and to everybody. Next slide, please. So John stated it, you know, to kick this off, that, you know, the number 3 cause of death in the United States is preventable medical errors. That's about 1,000 lives per day and about $1 trillion each year. So we brought in, you know, medical errors to include situations where, you know, the patient's medical care has contributed to death. So there's human error involved in this. That, you know, you can't eliminate, obviously, in some of that practice, but there's a lot of things that we can do that can help this. Can you tab once, please? Thanks. You know, another story here is misidentification of a patient, and that patient clinical data, where there was a Minnesota patient, obviously, underwent a bilateral mastectomy for cancer, only to find out that actually it wasn't her record. You know, that's obviously a pretty traumatic experience. The levels of severity can range, obviously. You know, I think pulling some of these stories out to really resonate with folks and capture attention is very key. And it's more than just deaths. It's the complications that occur for treatment, drug management, other just common everyday things. So another key example would be, you know, Kathleen Taylor and Kathy Taylor. True story. I know the individual this happened to, and when she shared this story, I was shocked. Goes to her, has a local pharmacy that she goes to, and she's listed as Kathleen Taylor. She happened to have to go to a clinic for something, said her name was Kathy Taylor, goes by both names, was very sick, got a prescription, went to fill it, got medications. Those medications interfered with her regular medications, and because those looked like 2 separate records, she ended up in the ER to have to deal with that interaction. So that was a very simple interaction we all go through today. Nobody wants to have to go into their main PCP when they're sick, so you may go to a clinic or somewhere else, depending on how that information goes through. That's a very common use case occurrence. And that's an opportunity where the UPI would help with that. Next slide. So what's the negative impact on poor patient matching? So there's a couple of different areas that we, you know, synthesize the information down to help to resonate here, which is patient safety. So statistics show 86% of clinicians have witnessed a medical error. So when that happens, that data flows through. And in general, you know, that's a high number. We all want the best safety for our patients. We did say that more than half of all the deaths attributed to medical errors are identity related. Operational efficiencies. So depending on the language you're speaking and what resonates to you or your mindset at that time, I think everybody has compassion to these stories, but from a business perspective, you know, to know that an average hospital has an 8 to 12 duplicate rate, how can you fix that efficiently to prevent any of those downstream impacts? Because having a duplicate record can have multiple impacts just beyond the few that we've mentioned here today. And then the cost to remedy them. So what's the work involved to actually get through that? It could be close to $100 per duplicate pair. So you're looking at additional operational efficiencies and cost savings. As I said earlier, you know, understanding your budgets, where you can spend your money, where you can reallocate them. Healthcare is no different than any other industry. Everybody's trying to make the most out of what they get in terms of resources, budget, et cetera. So being able to reallocate the right resources and shifting their priorities perhaps on other things is a huge benefit. The third piece here also is the revenue cycle. So again, healthcare is a business, it is an industry, but understanding that as that information flows through that ecosystem, it can also not properly flow for a claim status. There also may be payment delays. Are you accessing the right person? So being able to kind of unify all this information, provide that 360 view of a patient, being able to not only communicate with them upstream, downstream, be able to collect your payments, et cetera, those are huge pieces that overall both go into patient matching, but as well as from an operational perspective. Next slide, please. So some of the other areas that this hits on, I've slightly alluded to them, is there's other pieces that can happen out of this. So obviously there's legal issues. So any of those instances I just mentioned, legally, I'm not a lawyer, but they would give me a lot of heartburn and headache, and they do in general as a consumer, as a patient, and somebody working within healthcare of, wow, how did we miss this? What happened? How do you fix it? I think another big piece that we underestimate is our patient trust. We have statistics on patients not being trustworthy, and I think a lot of that is contributed to healthcare technology and understanding that it's behind. How do we bridge that gap? We need to build patient trust in addition to brand. So, a common problem we have is if you have a bad experience with the brand, you'll tend to tell that to somebody 7 to 10 times more than when you have a positive one. You don't want that happening. In addition, though, you also want that sense of community with your brand. Some of the other basics is, again, readmissions, poor outcomes, proper care, really just getting into that patient piece, and again, making sure that we effectively keep the patient at the center of this, but understanding there's a lot of other pieces that are just as important. Next slide. So how did the industry get where it is today? So we've obviously talked in 2009 about the HITECH Act. We've talked about how there is no national patient identifier. Talked a lot about the medical problems that have happened around misidentification, but also the other impacts just now that can happen when you don't have clarity on the unique individuals that you have within your ecosystem. There's a reliance on, patient data. So I tell you something, and depending on how I'm feeling that day, I may just, yeah, that's good. And it may be incorrect, and I'm thinking that's just fine, and that's part of a problem too. Some of the matching technologies that have been out there that are legacy, while they can be good to a degree, there's definitely a lot of room and gaps that exist within those. And then lastly, MPIs, EMPIs, so those enterprise level matching that happens, which does happen today with a lot of organizations, is just not enough to create the larger interoperability that we need within our ecosystem. Next slide. So one of the very big things that stood in place on a national patient identifier for years was legislation. So there's been a law in place for 2 decades, and that was a ban on a national patient identifier. And for quite some time, that ban didn't prevent folks, but it deterred folks, obviously, from going ahead and creating a national patient identifier. More than a few years ago, individual entities have been working on that, but there is not a national patient identifier today that exists. So this happened in 1988. That was the original ban that said there's a belief that a national patient identifier was unwarranted government intrusion into private health care. So it got around some privacy issues. Why should we be saying that? And there's actually just a bigger play. Again, kind of throw the curveball at you. Where were you in 1988, and how much has changed now? It's 21 years later. It's a long time. And we have a lot of, technology and other pieces and factual data points to help us understand what we can do to keep moving this forward. We have a lot of options to kind of strike a balance here between patient comfort, security. We've learned a lot. There's so many more technological advances in play. So while there's still a lot of work to be done, we don't want healthcare to keep falling behind. So ban is in place. There was an announcement in July of 2019 that the House voted to overturn that ban. So all the reasons we just covered around the importance of having a UPI. So while the House opened the door for it, there was still a bill that would have to pass through to the Senate. Next slide. So where did we land? So it's been quite a bit of a journey. There was some delays with that, but just as of Monday, the Appropriations Committee released text of the agreement on the bill, and that final bill will maintain the ban on the UPI. However, it does require the ONC to conduct a study and submit recommendations back to Congress. So this is the first time since the ban that has enabled anything to come up and allow even HHS to recommend some standards. So it's a step in the right direction. I know we're all very hopeful. I know Experian Health and NCPDP, independently and jointly are going to be able to continue to make strides and push and influence this as much as possible. It's so important that we rally behind and understand how we're going to identify everybody, keep that standard going, and kind of decrease all of these other pieces. There is a lot of money, billions every year, and problems with misidentification, obviously legal costs, patient care, collections of bills, as I said, all of those things that we really need to be reevaluating and making strides for this. So while independently we can continue to do this, we need to also, we want that government support there as well. Next slide. All right, so we've talked a lot about how we got here, talked a lot about the HITECH Act. We've talked about the Universal Patient Identifier and its kind of role and how it can help bridge that a little bit. So we want to get to the next step of this, and that would be the solution at play. So I want to outline here how the UPI can do that efficient and accurate matching that we talked about, and be able to play a key role here, and give you a little more insight into how that works and understanding of it. Next slide. So if we just step back into more of that personal consumer level is, in healthcare, we all know this, your life events and your health events do not always line up. Use a common example of Maria Lisa Lopez, born in Houston, September 10th, 1980. So you have a life event and a health event. Both of those happen. Oh. One second, my monitor went out, sorry about that. In her health event, she goes back in 9 years later, and she actually, into hospital A, and she's actually been diagnosed with diabetes. Fast forward, more than a decade later, Maria Lisa Lopez moves to San Diego. She is living her life. She knows she has diabetes. Onwards as she goes, she gets married, becomes Maria Lisa Garcia, and decides, hey, we're going to move back to our hometown, Houston, from San Diego, and does that in 2014. 2015, Maria Lisa Garcia goes in and gets blood work done at the hospital in 2015. Both of those life events have key different pieces of information. She returns back to that hospital. She may have forgotten that she was there at any given point and puts herself in as Maria Lisa Lopez or Maria Lisa Garcia, even though previously she was Maria Lisa Lopez. Probably not going to mention she got married because she's forgotten about the test she had 15 years ago. I think most of us can't remember a lot of the things that have happened in the last 5 years or medications, et cetera. So rather than putting the onus on her to remember everything that has happened in her patient history, let's shift the focus and say we have all of these data points together. So why don't we go ahead and understand, should those records be merged? Do we know who that is? How should we look at that and get that holistic view of Maria Lisa? Next slide. So how can you go about doing that? I previously mentioned that there are EMPIs out there. The UMPI is a little different. It's a universal patient identifier. So if you look on the left here, EMPIs are listed out, and they all have their own EMPI index. So I'm Victoria Dames. In my physician's office, I have number 123. When I go to the pharmacy, I am number 7923A. All of these have their own unique number to work within their own systems, which is great. That serves a single purpose. The shift needs to be to more of a universal identity manager and looking at that holistically to say, okay, Victoria Dames, you went to the hospital, you went to the pharmacy, but we can see the connection here and understand. You may have seen your doctor here, you're getting medication here, you've been administered this. If you go to a PDMP, what's everything that's been going on with you? Let's get that clarity. Next slide. So how do we do that? So I mentioned that merging these records, understanding the two different individuals. Obviously, looking at this, unless you know a person, can be hard. If you look at these two different individuals here, Maria Lisa Lopez, Maria Garcia, if I didn't tell you the background or story, you would say, those are two different people. We have reference data, and what that means is, so Experian specifically has a very deep repository of verified reference data. And what we're able to do here in order to assign a UPI, by using the methodology of using reference data, what we do is we're able to go ahead, run both of those individuals through, understand everything we know about each of them, and see, do we have the confidence to say that that should actually be the same person? Next slide. So the information in pink is what we're able to append to each record and say, is Maria Lisa Lopez, Maria Garcia the same person? So if you look on the left, Maria Lisa Lopez has other names. She has Maria Garcia listed. She has Maria Lopez listed. We also see some historical addresses for her. If we go to the right and look at Maria Garcia, we also are able to see her other names listed. We were also able to fill in the SSN. We were also able to complete the address because it was not sent over completely. We were also able to look at other historical addresses. By using all this information in our algorithms, we're able to come through and say, okay, this is the same person. In that pink box on the bottom, you'll see the universal patient identifier, been assigned. It's going to take those two medical records, say these are the same person, return that back to an organization. The patient, the end user, never needs to know their UPI. It's irrelevant. It doesn't matter. You don't know the identifiers within all of your financial institutes. You don't know the identifiers within the auto industry. There's plenty of places where people are assigning linkage to things. This is a persistent link throughout all of healthcare that's going to be in place. So you never need to know it. It's not your responsibility. You don't tell people what it is. Obviously, that would not be something that you would want to do anyway. This is something that has to be run real time, gets assigned. There's constant data changes happening, and that's how you ensure the best confidence and accuracy. Next slide. So if we shift this over into a pharmacy example, you have a record from pharmacy A, pharmacy B. You go ahead, you have a Kathy Wilson and a Catherine Nelson. This is an exact example of Kathy Taylor. We have different information on both of these records, but we're not certain what to do with them. You look at both of them and you say, nope, those are two different people. Click to the next slide. Thank you. When we run this through, we're able to go ahead and get that additional information to create the overlap and understand with confidence that actually Catherine Nelson, Kathy Wilson are the same individual. We go to the next slide. So we've gone through obviously the whole digitization. We've talked about how this works, obviously provider, pharmacy space, given a couple examples. You know, for different folks on the phone, I'm going to put this out there to give a little more color. You know, these are real-time calls made behind the scenes. So this is no different than running an eligibility check for your insurance. Something that runs, comes back, patient doesn't know, that end user does not know. It's something that is technologically there to help improve the outcomes, give a better integrity to the processes that we're doing. So one of the case studies that we have is with a large provider. So they had a problem. They knew, openly admitted, that their EHR vendor matching isn't strong. Actually went through blatant examples of this. There was some probabilistic matching there, just was not good enough. Not their strength. It's a great EHR system, but just not, matching is not their, in their wheelhouse. And so they know that they had duplicate records. They're also looking at doing additional mergers. So they knew that they could be introducing more to the problem. So beforehand, they had actually a staff of 8 people reviewing possible duplicates. And they also worked with a third party to help expedite that process. So that was additional cost that they had to incur. Some numbers to use here was an input of 10 million, recognizing 300,000 duplicates. How did that UIM match justification work? So again, assigning UPIs to everybody, understanding how many duplicates are in there. We provided back the justification on why or why not. So sometimes they need additional data. We were able to do that and give them that information. They were able to reduce that fallout rate. The UIM saved them 4 minutes per match, so you're getting into that operational efficiency, eliminated additional costs, so that's money they could reinvest in other areas and solutions, and then obviously the staff allocation, so enabling them to refocus on other things. Next slide, please. And this current case study is one that's actually in progress today that we're working with. And again, I know I have duplicates in my system. I have multiple data sources coming in. I need a way to reconcile this down and have a universal key here. Can you help us? And we said, sure. So manually, they're kind of handling some of these instances as they bubble up for them. Input file, a little, almost 4.5 million records, obviously a much larger total universe. But looking at the matching solution, we were able to find 30% duplicates with this subset. Again, the range can vary. We see 8 to 12, as high as 20%. You'll even see quoted out in the marketplace. 30 is a little bit higher than normal, but that's a range that we see commonly. So that's a lot of different and disparate records out there. You know, in addition to that, we were able to provide additional insights to them around invalid phone numbers that they had on their files. So again, how are you going to contact your patients and the importance in that. Very interested on the next steps here for more to come. Like I said, this is in progress. So I think next slide. All right, next slide is our post-test questions. So I'm going to go ahead. I will read these. And Yvonne or Tammy, tell me if I'm doing this incorrectly. I'm going to read these. I'll go through the examples, and then I'll share the right answer. Or do folks have to submit an answer in real time, and then I'll close it?
Yes, so read the question, and then we'll display the answer.
Okay. I'll start with number one. Why is the HITECH Act of 2009 important? So A, it forces providers to update their technology stack. B, created to promote and expand the adoption of health information technology, especially through EHRs. C, coach medical staff how to speak about technology. Or D, enabled patients to treat themselves. Advance the slide. The correct answer is B, created to promote and expand the adoption, obviously the digitization of healthcare. Next question. When was the National Patient Identifier banned? 2 years ago, 5 years ago, 21, or 100? All right, we'll go to the next 21 years ago. I think I gave a couple good hints on that with the 2 decades and 21 years on the slide. Next one. What is a UPI? Understanding people's information. B, unique people inquiry. C, universal patient identifier. Or D, universal person information. All right, go ahead. Universal patient identifier. Number 4. What are the benefits of utilizing a UPI? Every patient can receive a persistent identifier throughout the healthcare ecosystem, prevent duplicate records, receive government funding, and option D is only A and B. Go ahead and reveal the answer, only A and B. All right, next question. What areas can take advantage of the UPI? Providers, pharmacies, payers, or D, all of the above? And go ahead and show the answer. D, all of the above. All right, next slide is questions. So I know we have a limited time here. I'm going to go on mute here in a second and cough, but I was going to ask around questions. I've seen some come in. I'll address a couple of them and take a pause here, but
Thank you, Victoria. Thank you so much, John and Victoria, for presenting today. We do welcome our audience members to participate in the interactive discussion by submitting your questions in the Q&A box located on the bottom right of your screen. We did have a question that came in, and I believe, John, you were going to address this one. What are the plans to make the UPI available to the patient so they can be an active participant in ensuring their records are complete and accurate?
Yeah, great question. As we evaluate the UPI from our standpoint is not intended to be a patient-facing number. Victoria kind of went into the fact that, other commercial entities have numbers behind the scenes. And one of the main reasons is we are out advocating and educating, especially when we're on the Hill in Washington, is that we want to make sure that there's an effort, and the reason that this is behind the scenes is to make sure that there's no misuse or to prevent misuse of this number or this identifier, and so it does not get into the wrong hands. In addition, the UPI does not collect or share any clinical claims or diagnostic information. Therefore, that's why, per our recommendation, it's a behind-the-scenes number for trading partners.
Okay, great, thank you. And we did have a second one that came in. Don't countries like Denmark and Taiwan have UPI? What USA prevents adoption of UPI?
So I could address part of that one, and my voice is starting to go. Part of that has to do with the ban. So when the ban was instated in 1998, obviously around conservative thoughts around patient privacy, or why should the government get involved with a UPI. So we have a UPI. There's nothing preventing the USA from adopting it. We're individually doing this with companies like myself, Experian Health. The government and the ban specifically around this was looking, they can obviously look at what has happened in other countries. There are UPIs in other countries as well. And so there's nothing preventing us from this. So there's two different pieces with the ban and the UPI. There's nothing preventing adoption. We're actually working with hundreds of organizations today to start and continue to keep using the UPI.
Okay, great, thank you. Those were the only questions that we had received. If anyone has any questions, feel free. I did want to remind everyone that we will provide, this is a question that I had received numerous times throughout the presentation. We will provide a recording link and a copy of the slides and the CPE information in a follow-up email. We'll send that email to the email address you used to register for this session. So we did get that consistently. I did want to address that question. There is one that just came in. As a payer processor, is the UPI something that we would be receiving in the claim transaction in the future?
So yes, I will say that is our goal. We do work with payers as well. Again, not a requirement. However, it is definitely something that our goal is interoperability everywhere. So meaning the ability to understand where it's relevant to utilize that UPI to share and move information around, whether that's within your own entity as a payer or between entities such as provider and payer.
Okay, and then we have a final question here. I have never knowingly connected to Experian creating a UPI for me. How do I get my UPI deleted?
So I'm looking here at the question. So a UPI is something that is something that's in pretty much everyone's database. So you probably have a unique identifier located within every database that you've ever accessed to or ever been a part of. I'm happy to contact this individual offline to discuss this further because I think there's a little bit of confusion. The UPI is not something that a patient ever knows. It's part of a technology solution, and how that works is that information gets passed to link appropriate data together and or to identify an individual. No different really than how you're able to make up a 360 view of yourself, for instance, for your financial information and understand, is this the right data for the right person, and making sure all that information comes into play together accurately and efficiently.
Thank you. So that seems to be the end of our questions at this time, Victoria. Thank you so much for the presentation. We did want to just go ahead and make a couple of announcements. We get to the next slides. So just as a reminder, attendees participating in the portion of today's session will provide a follow-up information on CPE, this evaluation link, and you must post within 60 days to obtain that credit. Next slide. So May 6th through 9th, 2020, join NCPDP at their annual Technology and Business Conference, Dream Big, Act Now, in Scottsdale, Arizona. We will provide a follow-up link and registration link included in the email. Next slide. And finally, March 9th through 13th in Orlando, Florida, the 2020 HIMSS Global Health Conference and Exhibition will bring together nearly 45,000 professionals for education, innovation, and collaboration. So again, thank you so much for attending today's presentation. Thanks again to our speakers, John Hill and Victoria Dames. Thank you all for attending, and we wish you a happy holiday.